Hi everyone. Our discussion today is demystifying heart failure. The whole aim is trying to make things as simple as they are truly, although they could be a bit complicated. But at the level you are, how would you be comfortable managing a patient with heart failure? What are the key things to do? And our discussion today is going to be a discussion. It's not a didactic lecture where I'll be saying things. No, it would just be two cases only. We would go through those cases one after the other. I would expect your input in the management of the cases, and then I'll chip in a few things for the first one. And for the second case, I would want it to be more of your contribution in the discussion rather than myself. But just before that, I'd like to start with saying that heart failure is a clinical syndrome, as we all are aware of, and it presents in clinical forms. So we have majorly about 4 presentations of heart failure. We have the acute heart failure, or we call the acute decompensated heart failure. This is a situation where you find a patient that was previously well and is now presenting suddenly within a short period of time with clinical presentation of heart failure. It could as well be known patient with heart failure in the past that is stable, and then all of a sudden within a short period of time decompensated and being unwell. We have other people that are heart failure patient that are known to have heart failure for some time, and they've been unwell for a couple of weeks or months, and you see them, this is a case of decompensated heart failure, but there's no acuity in this one. Like the management strategies differs for a patient is an acute and a patient that is not an acute decompensated heart failure. And of course, out of those patients with acute heart failure, we have a major concern with patients that are in cardiogenic shock. That's people with low blood pressure and also evidence of hypoperfusion. And then we also have the people with heart failure that are stable. The people, there's a patient with heart failure, you know them, you see them, they're known to have heart failure, whatever form of heart failure they do have, well medicated, or even if they're not well medicated, but they're stable hemodynamically and clinically. So symptom-wise, they're okay. Knowing this 4 presentation is very important because the management strategies for each one of these is a bit different. That would be my first main introduction to clinical presentation of heart failure. And we go to our first case then. So our first case is a 72-year-old man who's a known hypertensive with the previous infarct, was presented with sudden shortness of breath for a couple of hours. He's now breathless, as you're seeing him in ED. He's unable to lay flat. He's had episodes of shortness of breath at night, waking up with shortness of breath. And he's also reported recent cough, productive of frothy, pinky sputum. He's also noticed recently that he's been getting worsened swelling in his legs. Examination-wise, general examination is distressed, tachypnic, hypoxic with saturation. His blood pressure is high. His heart rate is tachycardic. Cardiovascular-wise, he has a raised JVP. He does have third heart sound. He has some crackles in his back. And you've also noticed bilateral lower limb edema. So this is a typical scenario you would see either while you are in the ED, you are in AMU, or you're on call when the nurses call you that we've got this patient that is unwell. What do you think? And what would you do? Please feel free to chip in. Like I said, it's a discussion. It's not this is not aimed at anyone or pointing at anyone, just contribute in the discussion. I want us to discuss the case and see how we would manage this type of patient. So please feel free. You could speak with your mic, or you could also write in the chat. Are you with me there? Okay, bedside investigations like ops. Okay. Okay, excellent. So we start with A to E assessment of the patient. That's perfect. Excellent. He's hypoxic, oxygen. Excellent. So AE approach, get a full set of ops, chest X-ray and IV furosemide. Excellent. Any more inputs? Sputum sample. That's wonderful. ABG. Good. Now, yeah, consideration with my, yeah, what might, excellent. This is very important. This is extremely important when you are seeing a case of suspected heart failure or a patient with decompensated heart failure. You think about what could have been the trigger. Could it be an etiology you could pick? Is there something that is precipitating this? So I think we'll chip in just to save time, and then we go together along with that pattern. So this is an acutely unwell patient we're seeing, being that he's been short of breath within a short period of time. Clinically, he's short of breath at rest. His hemodynamics clinically not stable. You can see that this patient is hypoxic, he's tachycardic, he's a bit of hypertensive, his JVP is raised, he has bilateral low limb edema, his back has crackles up to the mid zone. So this is a typical picture of a patient with acute pulmonary edema, or it's an acutely unwell patient with heart failure. So the scenario itself pictures a case of acute heart failure. And if you're seeing this patient in an ED, then yes, the first thing you do is go with your ABCD and take this patient to a resus bed, because there you have much more resources available. He's hypoxic, so you quickly get him to have an oxygen, quickly get access to this patient quickly, take bloods, do basic investigations. Now the purpose of this is to pick out any etiology, any precipitant. Has there been any complications? So checking the full blood count, checking if this patient is anemic, because you could find this patient is having a HB of 6. We've had patients with acute heart failure. They've been symptomatic for some time, but all of a sudden they're unwell. HB 6 point something. Inflammatory markers are up. He's having some AKR. His creatinine is up. His potassium is low. Very unwell patient, you know. But basic things. His HB is low. You know, correcting that would be the key for you in his management. Checking for NT-proBNP. It's now standard practice when you have a patient that is acutely unwell, shortness of breath. You do NT-proBNP. Lactate, because he's very unwell. They could get, although his blood pressure is high, but sometimes he could decompensate and he gets hypoperfusion. ABG to check his saturations, because these patients, although he has a clinical picture of heart failure seen now, and ABG helps in showing if this patient is only having a type 1 respiratory failure, or he's in type 2 because he could have been out of breath for some time and he's tired and exhausted, and you know his difficulty catching his breath, and you know that I'm now in type 2 respiratory failure. Of course, the other investigations, CRP, chest x-rays, LFTs. LFT tells you if this patient is congested or not. A quick bedside echo if it's available. Otherwise, you can request that for someone to come do that. But this is just something you do in a brief. You may not be able to do all this together at the same time, but do the key things. Very important when you establish access, you give them IV furosemide. So if this patient has never been on furosemide, has never been on diuretics before, you go slow and you titrate. But if this patient was on diuretic before, then you go to either his regular dose or preferably going 2 or 2.5 dose of what he was previously. This chap has a high blood pressure, so depending on the ops, if his blood pressure is anything around 150s and above, you could consider giving him some nitrate, as they are helpful in pulmonary vasodilatation, and that could help with his breathing. Making sure this patient get regular ops as suggested by some of the colleagues. Check if there's anything that is precipitating this patient's heart failure. Is it infection? Is it anemic? Is it tachycardic? Because he's in AF, is he having some funny rhythms there? You're looking for anything. Is he in chest pain? Does this patient is having any chest pain? Was it an ACS that precipitated him to be that? Could it be that in this case it was tachycardic, but some other people could think it could just be bradycardic? You know, so do this. This is your first line in the management of any patient you're having with an acute heart failure. Access, investigations, diuretics, telemetry, and check for any precipitant and treat for this patient. Then also input-output. As the patient stabilizes, ensure that he gets daily bloods because he might be on the ward and you are at night, so you put your plans well. Stay on any disease-modifying medications. You assess, is he able to tolerate that or not? And then which one would be the best to start with? Because if the patient has having AKI, you wouldn't start with ACE or spironolactone. Like this patient is an acute pulmonary edema, so it's unwise for you to give him beta blocker until you know that this patient is stable. If he has any signs of infection, you would not give him an SGLT2 inhibitors because then you know they are contraindicated, and then you know that the complications there. If his lactate is up, you know he's already in lactic acidosis, so giving him some some DAPA or empagliflozin is an unwise decision to do. If a patient is stable on the ward, then you need to involve the heart failure nurses. If this is patient, you've managed him while on the ward, you have had this scenario, he's now stable and is going home, then in your discharge, you should not forget to involve the community heart failure nurses in the community manager. Make sure you arrange a clinic follow-up for this patient, and in the management of this case, make sure the cardiology team is involved. Any questions so far? So we go to the next case. So this is an 82-year-old lady who's known to have hypertension, AF, type 2 diabetes, and she's obese. Now she's presenting to you in clinic. She's presenting to you in AMU. And yes, like you're seeing her. Oh, she's on the ward. She's been admitted because she's short of breath. And the nurses are saying that this lady, she's just not well. She's been short of breath for about 2 days. And you're now seeing her. She's orthopnic. She has a PND. She's got ankle swellings. She obviously has no any chest pain and no any signs of infection. She's had a previous echocardiogram that shows she has an ejection fraction of 55%, more than 55%. Examination-wise, she's breathless when you came around. She's tachypnic. The blood pressure is slightly elevated. She has an irregular heart rate. Her apex, is JVP is raised. Her apex is not displaced, and she has bilateral lower limb edema. Her heart sounds are normal. What do you think? And what are your differentials here? Please put your differentials in the chat. Yeah, back to the slide. Fast AF, PE, decompensated heart failure secondary to fast AF. Any more options? And how would you manage the patient then? Okay, silent infarct. So for the sake of time, so this is a clinical scenario of a patient with heart failure. Patient is previously known to have a normal LV, but he has loads of cardiovascular risk factors: age, hypertension, AF, diabetes, and obesity, and now presenting with shortness of breath and other things. So it's a clinical scenario that's suggestive of heart failure. What are your differentials? So my top differential will be heart failure. Could it be heart failure with preserved ejection fraction? Yes. Could it be that this patient is now presenting with symptom heart failure, but that is precipitated by AF? Very possible. He's in tachyarrhythmia, and now he's having presentation with decompensated heart failure, as that can present with that. Could he have had an infarct, and now as a complication of the infarct, now presenting with heart failure? Yes. PE, well, it doesn't add up to PE, as he does have other symptoms that will not be in favor of PE here. And patient has got AF and is already he has high charge vascular, so you would find this patient normally on anticoagulation. So the risk of PE will be slightly low. But this is a typical case of heart failure with preserved ejection fraction. When you see this patient is not as unwell as the other patient you've seen. You would find these type of scenarios in hospital, in the bed, on the ward. Patient admitted with shortness of breath. He's not unwell. You've been called to see him. He's a bit of, you could see that he's really a case of heart failure. You do some investigations. So you would normally find that this patient must have had some investigations done. If none is done, or basic investigations are not done there, you get his x-ray, get some bloods for the patient, give him some diuretics, and then also see if he's had an echo done, or you need to request an echocardiogram. Make sure that an input-output chart is there for this patient. And then while looking at all that, seeing that that this patient has no chest pain, so we know he's not had an infarct. He's not having any signs of infection, which is quite reassuring in the management of this patient. So we know that two of the major precipitants of he's in AF. What's his heart rate? Is he fast? Because if he's fast, then controlling the heart rate will be very helpful in the management of your patient. So does he need to be, do you need to give him more beta blockers? Does he need to be on some digoxin? Those are key things to do So looking at any precipitant you have there, addressing that precipitant, give him adequate diuretics, and then referring this patient appropriately, because you are an FY2, so usually when you manage the patient, then you escalate to the next appropriate ladder of escalation. So generally, heart failure is it's a simple thing to manage that can be a bit tricky. Knowing the key things in the management is essential. Whenever you have a patient with heart failure, recognizing it as a clinical diagnosis, starting getting your basic primary investigations you will do for everyone, including a chest X-ray, making sure this patient has adequate diuresis, is well diuresed, making sure his saturation is okay, and then requesting investigations like echocardiogram and early involvement of cardiology wherever you have a challenge or senior as required. This is my last slide. So the first case is a typical case of suspected case of a heart failure that is very likely to be heart failure with reduced ejection fraction or mid-range ejection fraction. Acutely unwell. He has an S3 there. So having tachycardia and S3 would mean S3 gallop, which would suggest this patient is having heart failure with reduced ejection fraction or mid-range ejection fraction. And the second is a typical case of heart failure with preserved ejection fraction. So heart failure with reduced ejection fraction is a patient with clinical heart failure with an echocardiogram or a cardiac imaging evidence of EF less than 40 or less than 40%, while a mid-range is an EF of 41 to 49%, and heart failure with preserved ejection fraction is EF of 50 and above. The management of all patients with heart failure being unwell is primarily the same in terms of diuresis investigations you do. The disease-modifying medications normally differ a bit, but based on the recent NICE guidelines, HFrEF and HFmrEF would normally have the 4 pillars and diuretics, while the HFpEF would have 2 pillars, and the 2 pillars are normally SGLT2 inhibitors and spironolactone or MRAs with diuretics. Advanced heart failure therapy would be decided by the cardiology team. I hope I've been able to do some revision for you to your heart failure information. Please, if you have any questions, feel free to ask. Thank you very much.